He said he wasn't gonna need these because you guys are just gonna talk. He won't have to call you out by name. Yep. Water.
What's up? Y'all, I want to tell you, we have to have a heart-to-heart today. It's that serious. I've been a little grumpy this week. And all my social media friends are getting mad at me because I'm blowing up their news feeds with material that I've put together for these past 2 lectures talking about the health insurance market, healthcare reform, the new bill that's on the table being pushed through the Senate right now, the Graham-Cassidy bill. So you're all going to have to forgive me because normally I try very hard to be neutral and present you with information and let you kind of sort through and make your own decisions about what that information looks like and means to you. But you're going to have to forgive me because there are probably going to be points during this talk where it will be very ugly language coming from me, so just know it. And I'll tell you why, because the point being that when we kind of go through some of the issues leading up to the ACA, what the ACA actually did, and then we start talking about what's on the table and how that will unwind it, and the implications for that on people, right? Like that's something that's okay to be upset about, right? Like in my opinion, that's something that's legitimately okay to voice some concern over. And so if you hear me do that, please forgive me now. So what a week to discuss healthcare reform, right? Like you couldn't have planned this any better. Anyway, don't go trying to look at my Facebook feed to see stuff because, I won't accept your friend request until after you graduate out of principal. So you'll hear it all out here anyway. So it's like I said, it's an interesting week to talk about healthcare reform. There's a bill on the table, and I'll kind of pull some of those in as we talk through it. But what I want to do is just kind of start. We talked a little bit about this yesterday, but last week. But just to make sure that we kind of carry that information into this week, all the things that we talked about health insurance market, how premiums were set, all the issues that were going on around that, really, for the most part, predated the ACA. We talked a little bit about some of the things the ACA does to level that playing field, but I want to make sure that you're able to connect what we talked about last week with what we're talking about today so that the ACA stuff will make sense and then everything else that's happening will make sense too. So just quickly, we're going to talk again about cost, assets, and quality prior to the ACA so that we're all kind of carrying that information forward. So we've already established that healthcare spending in the U.S. is not just higher than every other industrialized country, it's like ridiculously higher than every other industrialized country. So we pay a lot more for healthcare than other countries do in general, and what do we get for our investment? Not much, right? Life expectancy is lower. We live, not as long, and the years that we do live are not really as high quality because we're dealing with lots of multiple chronic conditions that are very costly and so on. That's an issue. We talked about this study from Massachusetts that came out in 2012. Anybody remember that from last week?
Yeah.
Right, so what was the punchline there? You can read it. It's cool. Yeah, so they looked at the Massachusetts healthcare reform, which was the blueprint or the template for the ACA. As good as research as you can do, right, outside of this research, the way they set this up was as good as you can do outside of a randomized controlled trial where you assign an intervention to someone and a group doesn't get it. But I will never be able to do that type of study again because there's enough evidence to suggest that insurance is so important that it would be unethical to withhold treatment and do this type of study again. So think about the irony of that as we talk through the ACA. So basically, for every 830 who gained health insurance, 1 death was prevented. Some back-of-the-envelope calculations, you're looking at about 20,300 potentially preventable deaths that we would expect to see under the ACA. So insurance is important, right? And you could reasonably argue that it's a matter of life and death for some folks, right? So start there. Prior to the ACA, this kind of highlights what's happened to some degree following the ACA, but you can see that about 15% of the population on average prior to the ACA didn't have health insurance, right? It's about 46 million, 50 million people or so. So there were a lot of folks prior to the ACA who just did not have access to coverage. We talked about why that was last week. The way insurance premiums were set, they weren't affordable. You could be denied coverage because you had conditions that the insurance company wouldn't want to take you. Like, there were lots of reasons why this was the case, but the fact remains it was the case. So in 2015, the uninsurance rate in the U.S. hit single digits, right? First time in 50 years that single-digit rates of uninsurance were observed in the U.S., right? So clearly, there's some progress being made here. We talked about the quality of care in the U.S. healthcare system. Actually, we didn't talk about that last week. I'm slipping one in on you here. I should have, but didn't. So we know about the cost. We know that insurance is important. We know that people didn't have access to insurance prior to that. One of the issues that's important when we start talking about the ACA and specifically on cost containment, this is a little nugget that you may or may not be familiar with. So there have been several studies that have looked at preventable hospitalization, which is I go to the hospital for something that I should walk out of. I should walk out of the hospital at some point, but I don't. Wrong site surgeries, mix-ups with medications, getting a deadly infection, whatever it may be. You go to the hospital for something that should be routine care, and you don't come back out, right? So when they do studies and look at all the deaths that occur as a result of medical error, how much do you think that is? How often do you think that occurs? Would it shock you if I told you that if you multiply that number out with the leading causes of death, it would rank number 3? Right? Just behind heart disease and cancer, ahead of smoking-related illness and accidents. Right? I'm not making this stuff up, right? Like, these are published research articles that get reviewed by really smart people. Like, this is not just, some blog.org making a number up, right? This study was actually done by Hopkins, so for whatever that's worth. So if you just look at preventable hospitalization deaths, right, like that would be the 3rd leading cause of death. So quality is important. So it's not just about giving people access to insurance. There's got to be some type of reform around the way that healthcare is delivered to improve the health and well-being of the population. But this is also tied to cost, right? Like, sometimes people go into the hospital for things, and they may not die, but they pick up other things that are extremely costly. Like, there are lots of other issues at play here, but just to put that on your radar screen, we have issues around cost. We have issues around access that are not just limited to insurance. We talked about access to care in rural areas and things like that last week. And we have issues around quality. Now, let me be very clear. I'm not pointing the finger at providers and saying they're doing a bad job. That's not it. It's just that when you talk about the U.S. as a geographic unit, these things are spread out. These are isolated cases in most hospitals, right? When you put them all together, it tells us this bigger picture story that we need to have on our radar screen and think about. So, again, providers are not intending to hurt people. They're not out to hurt people. Most of them are doing the best that they can. It's not bad providers, it's bad processes, right? We have bad processes that put people in positions where those types of mistakes can happen. So, that sets the universe for what we're going to talk about around the ACA. Okay, so just, if you need to take a few deep breaths, right, and think about it, let it sink in. If you want to do some burpees, you can do that. But I need you to get your mind right so we can talk about the ACA, right? So we're all kind of on the same page here. So the ACA, I had to update this, was passed 7 years ago. It makes me feel old because when I first started giving this talk, it was 2 years ago. Now it's 3 years ago. Now it's like up to 7. So it was passed in 2010. Originally, it was estimated to extend coverage to about 32 million people. We'll talk about that in a little bit. So there were 10 chapters, 41 subtitles, and when you kind of looked at it, you just boil it down to different initiatives. It was about 50 different things that they wanted to see done in the healthcare system, and that there's a broad range of stuff in there. There are a lot of, this is how policy works. There were a lot of programs that were added that really had nothing to do with insurance that people felt like were good to add. So there's a lot of other stuff that got crammed in there. But there were about 50 initiatives that were set to be implemented. The price tag, you little sticker shock here, was about $1.2 trillion through 2025. So, yes, that's a lot of money, right? So here's a news flash, right? Extending access to care to people who don't have insurance costs you money, right? Some people think that it's worth the cost. Some people don't. Like, that's just a philosophical debate that we have to have. So anyway, although it was set to come in at $1.2 trillion, it's repeatedly come in under cost estimates for various reasons, which rarely happens with programs. So obviously with, the totality of what was in the ACA, how many of you all, just 7 years ago, I don't know how old you were then, how many of you all remember flipping on the news and seeing senators with a stack of 2-inch ring binders up in the corner, and it went this high, and they were like, that's the ACA, who's going to read that? Y'all remember that? Or you two, you don't remember that? Right? Who's got a piece of paper? Let me see your notebook. You taking notes? All right. So, just so you know, how many of y'all read the ACA?
Not all of it.
Yeah, well, it's actually, so this is garbage, right? So when you actually look at the ACA, the narrative that's printed for the ACA takes up about 1/3 of a page, right? So when they talk about how many pages it was not that many pages. It was not as long as they tried to make it out to be. That was just purely political maneuvering and whatever. So it's not that difficult to read, right? And I want to talk about that in a minute, but it wasn't that bad. I mean, it took a while, but it wasn't a big deal. But there's a lot of stuff in there. It's not really so much this is what you need to do and how you need to do it. It's more of a general guideline, or these are the general things that we want to see accomplished. So it was more of a template to work from. But because it's so big and because we only have, 2.5 hours to talk about it, lucky you today, the easiest way to kind of think about it is, what are the parts of the ACA that we're trying to create access, right? Create access to insurance, create access to opportunities to have more affordable insurance. And what were the policies that were in there to try and help control costs, right? Because you know that if you're increasing access, that's going to come with a cost. So you kind of have to balance that out with trying to do other things that are designed to rein in the cost. So in my mind, it's much easier to kind of think about this into what's trying to help people get stuff and what's trying to make sure that what they get is better and cheaper, right? So like that's kind of the way that I think about it, or that's the way that we're going to talk about it anyway. So when we talk about policies to create access, we're going to talk through that. I'll give you a break and you can take a trip around the building, get some fresh air, do whatever you need to do. And then we'll talk about the cost side. But let's talk about the access side first. There are two big things that were designed to help increase access. And by access, I mean help people obtain more affordable health insurance or health insurance at all. And there are really two big things, right? There are multiple components, but there are two big things. One was insurance market reforms, and the other one was Medicaid expansion, right? Like at the end of the day, those are the big tools that were used in the ACA to try to help folks. So I'm just going to cut to the punchline, right? And I think it's easier to just go ahead and cut to the chase and then backwards talk about it. So when you look at what's happened since the ACA was implemented, right? So this data, this is the most recent data I could find, so like 2015, 2016 data. And just so you know, the American Action Forum is a conservative think tank, right? So these numbers came from a conservative group, not one that would have a vested interest in making the numbers look higher than they really were. So on average, right, so they looked at some of the different estimates that were out there and looked at the studies. On average, you had about 20 million people in various ways, shapes, forms, and fashion gain coverage under the ACA. Now, we need to be very clear, not all of those were newly insured. Some of those people had insurance before. They were just able to get a better deal through the ACA. But if you look at how that broke out, the vast majority of those, we're just going to talk about the average one here, but you can see how this will be the low side, this will be the high side. If you look at the average, you're talking about 10 million folks that got covered under the Medicaid expansion, right? So that's kind of the largest chunk that was made. You have close to 6 million that gained coverage through the individual market, right? So all that stuff that we talked about last week about buying insurance policies in the market and rating schemes and all that, These are folks who made too much money to qualify for Medicaid, but probably didn't have access to insurance through their employer, so they had to go buy insurance in the private market, right? That's these folks, this, roughly 6 million. You got another little chunk here of about 1 million folks that were able to gain access to health insurance through the employer mandate, which we'll talk about in a little bit, meaning that if you're a company that has more than 50 employees, you have to provide them some form of coverage, right? So there was a small chunk that gained access through that particular lever. And then this other chunk, which is interestingly the third biggest chunk, which may affect some of you in here, was the fact that you could stay on your parents' health insurance through the age of 26, right? I didn't have that luxury when I was your age, which is why I was uninsured for the most of my 20s, right? So those are the big, these are really the policy levers that were out there to help increase access to insurance. So we're going to talk through those because all of them are important and all of them contribute to this larger overall dialogue that we need to have around health insurance. So market reforms. Let's talk about this. So kind of going back, this applies to the folks that are in the green here. That 6 million that had to go buy insurance in the private market. The ACA changed the way that health insurance companies operate in these markets, right? So what you need to think about is when I tell you what the ACA did, what you should be thinking immediately is, oh, well, they weren't doing that before. What the heck, right? So that's how you should be processing this information. So here's the what the heck stuff. No denial of coverage due to pre-existing conditions. I'm going to show you a list of pre-existing conditions, and I'm going to make a very facetious comment when I do that. No limits on annual lifetime spending. What does that mean? No limits on lifetime annual spending. Somebody tell me what that means. Don't make me a liar. I said y'all talked to me last week. What does it mean?
Did I cut you off if you spend so much money on health care?
Yeah. So prior to the ACA, how much do you think that was? What do you think the average lifetime limit was on health insurance spending? Most positive is about 1 to 2 million. So if you have health insurance, your insurance company will only pay out $1 million on your behalf. What do you think happens when you cross that $1 million?
Debt.
You're done. Yeah, somebody's not getting paid. Like, I don't know. That's why they have children's hospitals and things like that. Why? So if you're born premature and you're hooked up to lots of machines for the first month of your life, how quick do you think you're going to burn through that $1 million? Yeah, you've already done, right? So what I need you to understand is that's what was happening before the ACA, right? This happened to lots of people. Like, you wouldn't even know it. When something bad happens to you, you're not thinking, oh, well, how much is my insurance going to pay? Am I getting close to hitting my million cap, right? So you would hit, middle ages, your child would get sick, God, I hate to talk about this stuff because I have small kids, but things like that stuff happens, right? Bad things would happen to people. They would burn through this really quick, and then they would just get a notice from the insurance company saying, sorry, we're done. We're not paying anymore on your claims, right? You're sitting there with millions of dollars of debt, right? It's ridiculous. But that's what was happening before the ACA. Stay on parents' insurance through 26. That's pretty straightforward, right? No big, good for you guys. Some of you guys. Some of you may be older than that. They said the medical loss ratios for insurance companies is 80%. So basically what that means is that an insurance company has to spend at least 80% of all the money that they're taking in from premiums on paying claims. Okay, so what the heck with that? What's the reciprocal of that? Those medical loss ratios should not look like that, which means what? Yeah, I mean, there was really no regulation on, you're an insurance company, you're supposed to be paying for care for folks, but, 40% of them, your medical loss ratios are like 60, 70%, which means that you're only paying, a third of what you're bringing in on what you're supposed to be paying for, right? Like, maybe you shouldn't be spending money on flat screen TVs in your offices and stuff like that, right? I mean, that's really what it was getting at. That's important. That's important because when we start looking about the stabilization of the insurance market, we're going to come back to that number because that's a really good metric for how stable the private insurance market is. Okay, so here, I told you I was going to show you this, and I'm going to make a very ugly comment here. This is a list of pre-existing conditions that used to be deniable in the private insurance market. Now again, this is not, if you have a job and your employer provides insurance, this doesn't apply. They have to take you no matter what. Okay, this is for people who had to go buy health insurance in the private market. Okay, lupus, alcohol and drug abuse, mental disorders, right? So just basic depression, schizophrenia, things like that. Multiple sclerosis, okay, arthritis, fibromyalgia. How many of y'all know somebody who has fibromyalgia? Be honest. Yeah, some of you may have it too. Muscular dystrophy, cancer, obesity. Now, I'm gonna, this is, the technical definition is severe obesity, right? So this is not just someone who's a little overweight. But if you're overweight enough, that's a deniable condition, okay? Hepatitis C, stroke. So if you had a stroke at some point in your life and you recovered, that's a deniable condition. So some of these you might expect, some of these you might not. Diabetes. Are you freaking kidding me? Diabetes is a deniable condition, right? Pregnancy. Don't get me going on that. Pregnancy. If you're trying to buy insurance in the private market and you're pregnant, they're not going to insure you until after you have a baby. Are you freaking kidding me? COPD, Parkinson's disease, Crohn's disease. How many of y'all know somebody who has Crohn's disease? Like, kind of related to gluten intolerance, whatever. So here's my question. What the heck was it deniable? Seriously. Like,
Breathing.
so here's, what was that?
I said breathing.
Yeah. So here's the kicker. And I'm going to jump ahead here. So I was listening to the news last night, and somebody had the nerve to get on camera and say, the new Health Care Act keeps these protections in place. You still can't deny, you can't do this now, right? Like if you have these conditions, you can go buy insurance in the private market now using the community rating scheme that we talked about last week, which means you can actually buy coverage and it's relatively affordable, right? So if this bill goes through, I can't believe they say this stuff with a straight face, right? The protections are still there for pre-existing conditions. Well, they're taking all the subsidies away. They're taking the market exchanges away. They're trying to put it into a block grant that goes to states. Technically, they'll not be able to deny you coverage, but what do you think they're going to go back to that we talked about last week? What's it called? Experience rating. They'll go back to experience rating, which means that they might, they'll make this so, if you try and buy it, they'll have to give it to you, but they'll make it so expensive that nobody will be able to afford it if you have one of these conditions. So technically, the protections are still there. Practically, it's not going to matter because you're not going to be able to buy them anyway, right? So it's total nonsense, and it's intellectual dishonesty, and it's ridiculous, right? If you're going to make the change, this is where I'm getting ugly now. Y'all going to have to forgive me. If you feel that strongly that we shouldn't be paying for this and that we need to reduce the federal budget and whatever, just own it. Don't act like it's better for the American people, because 20 million people losing coverage and this kind of crap is not better for people, right? It's not. That is my opinion. You are absolutely 100% free to disagree with that, but just own it. Don't lie about it. Just own it. Okay, I won't say anything else ugly. So, can you edit that out, Integrity?
I'll just put like a picture of like a smiley face
Yeah,
over your
smiley
head.
face.
Like, music playing.
And again, let me reiterate that. I think that's a legitimate discussion to have. Whose job is it to finance health care? Right? Is it a federal responsibility? Is it a state responsibility? That's a legitimate discussion to have. Should we take the money that's being collected through general taxes, however that looks, and invest it back in paying for health insurance for folks? Those are legitimate questions that we should be able to talk about. Those are legitimate questions that we can feel differently about. Those are legitimate questions that are part of a broader process of dialogue and discussion around health care. right? That's what needs to happen, right? There are problems with the Affordable Care Act, and I'll point them out as we go through this. That's what needs to happen. Don't pretend like taking insurance away from 20 million people, which is what will happen, is somehow going to be better, right? It's not. We may have to pay more, and it may reduce the financial burden, and if that's important to you, that's fine. But just, have some intellectual honesty about how you're talking about it, right? I mean, it's almost insulting to me as a consumer for you to stand in front of the TV and try and pull that crap up, like to say that kind of stuff, right? Okay, I'm done. I'm sorry. All right, I'm pulling the Jimmy Kimmel here. Sorry. All right. So health insurance exchanges. So again, these things were designed to allow people to go buy health insurance through the private market, create a space where insurance companies could offer plans and very transparent. You as a consumer can go look at what plans are available and pick, bronze, silver, platinum, whatever it may be. It established these exchanges. Again, we talked about this last week. It used a quasi-community rating scheme, right? So the idea that they're not going to charge you based off of how much you're going to cost them. They're going to charge you based off of how old you are, whether you smoke, and where you live, which is much better than the previous. The key here is that if you met certain income criteria through the health insurance exchanges, I think we went up to 400% of federal poverty. So if you made up to 400% of federal poverty, you were eligible for some discount on these premiums. So you could go buy insurance, you could pick your plan, and they would look at your income, and you would pay your premiums at a discounted rate based off of your income. Right? So the average subsidy that most people get buying policies through the exchange is about $272. So of all the folks who were eligible for a subsidy, that got a subsidy through buying plans in the exchange, they average about $275 per person, right? So for the most part, you're not paying $10,000 a year for everybody to have insurance, right? The average subsidy is $272. So here's the thing. Why would insurance companies do that? If you know that most of the people who are probably going to be buying insurance policies in this private exchange are folks who probably didn't have insurance before and they're probably a little bit sicker than average, why would you as an insurance company enter that market? If your primary objective is to make money, why would you do that? Anybody want to venture a guess why you would do that?
Government, think of money.
Exactly. You guys are smart. That's exactly why. The government knew this, right? Like with ACA, they knew that there's not really an incentive for companies there's no incentive for them. They're taking on a higher risk group. So it's called the Premium Stabilizer Program. So the federal government, as part of the ACA, basically subsidize not just individuals, they subsidize the insurance companies to get them to go into this market. Right? So the idea is that you're going to be taking on high risk people, so we're going to give you extra money to help offset that so that you'll stay in the market. Right? Because we need you in this market for it to work. Right? What do you think happened in 2015, 2016?
They stopped giving the subsidies.
The subsidy ran out. What do you think happened to premiums? You're darn skippy they went up. What started happening about the same time? I said this last week and said another really ugly thing. What do you think the insurance companies are doing or wanting to do now that those subsidies aren't there anymore?
They're
pulling out, right? So, that's important. I had to have this discussion with lots of folks. Listen, I have friends that saw their insurance premiums go up $500-600 a month. Like, legitimately. It's horrible. Like, I feel horrible for them. Like, it's bad. And I can explain why it happened, and I can talk about why it's worse in Tennessee than it is in states that expanded Medicaid, and I can talk about all these policy reasons why. But I think that it's important, while I'm making ugly comments about certain things, the reality is that there are a lot of folks who were promised that this would be okay, that they could keep their plans that couldn't. So I'm going to make some ugly bipartisan comments here. There were folks that were promised that they could keep their plans. That turned out not to be true. They couldn't. They had to buy into these markets with everyone else. Those are the ones whose insurance premiums are going up now. That's a problem, right? That was an over-promise, under-deliver for that segment of the population. My argument is that you don't throw away the whole ACA because you've got this really small subset that happens to. You can fix it pretty quickly and pretty easily for that group of people. But that's an issue, legitimate issue. And no amount of talk about policy and this and that changes the fact that people's premiums went up because they had to buy into this and didn't have a choice. Right, so I don't want to lose track of the human element to this story by getting lost in the policy stuff, so just keep that in mind. Another thing that
So does it mean the insurance market is not to blame? It's taking away the subsidy, that's the problem.
is it,
Yeah.
so are the insurance companies to blame?
Because
How do I answer that? So let's back up and think about it this way. Are insurance companies for-profit or non-profit? They're for-profit. So are they going to act, like this is kind of spilling over in economics here, are they going to act in a profit-maximizing manner?
Yes.
Absolutely. That's what they are. That's what they do. They're responsible to shareholders for bringing back a return on their investment. That return on investment is built into your premium. They're not going to lose that return on investment. Insurance companies are doing what insurance companies do. Like, it's not good or bad, it just is. Now, is it bad that they were willing to play when the subsidies were there, but now that they're not, they want to pull out? I think it's a little, I think it's a little not good. But they're acting in the best interest of their companies and their stakeholders. So they're let me be clear, they're losing money by providing plans in the ACA. I mean, that's pretty much been established. But at the same time, most of the big insurers are posting record profits simultaneously. So because they're losing money on one component of their portfolio, but making a heck of a lot of money on the other one, should they pull out the one that they're not making money on, even though it would benefit a significant number of people? I don't know. I don't think it's a right or wrong. It just is what it is. I know they're losing money on the ACA, but that's a very small piece of their portfolio. They're making record profits in every other aspect, right? So, yeah.
Should the rules that apply to medical insurance not be different from the normal insurance, Because I know that they're there to make money, but should the same rules of making money apply?
I don't know. Should we have a private entrepreneur-based healthcare system or not? I don't know. Those are different questions, yeah.
So when the bill was initially introduced in 2010, was the projected budget through 2025?
1.2 trillion through 2025, yeah.
So my question is, if the budget was projected through 2025, why did the premium stabilizer program end in 2016?
It was a short-term incentive to get the insurers in the market. The idea was that if you can get them in, then it'll stabilize, and it'll just kind of work out from there. I mean, it was always a short-term transitionary subsidies, right? And I'll talk a little bit later about what's happening, huh?
It didn't work out.
Well, it is working out to some degree. I'll show you some evidence that it's stabilizing. The problem is it's just stabilizing at a much higher rate than what people bought into it at, right? That's what's happening. So because of the stabilizers and because of the initial ramp up of the ACA, I'm kind of showing to the end here, what ended up happening was that people bought into the exchanges and got premiums that were artificially low. So when those went away and it kind of stabilized based off of who you risk pooled with, those premiums ended up going up in a lot of states like Tennessee because you ended up with a lot more sick people buying private insurance policies. And the good news is it was kind of a short-term jolt to the market, right? It just needed to correct itself. So it's not that it was wrong, it's just, it's kind of settling out at a higher premium than what they originally thought.
Don't you also think, sir, that if that's what you just tried to explain, if it happens in a short time, don't you think what they are proposing to will stabilize in a short time, and which is likely also going to, there's what I think, I quite understand, and it's really a very quite difficult situation.
Yeah.
But what I think is, you go A, you go B, you flip edge, you flip tail, it will still be the same.
I think that's a valid point, right? It's kind of a shell game. I mean, you're shuffling money around, moving this here, moving this there. I mean, that was kind of my criticism of some of the previous, repeal and replace bills that were been up. They're just taking the same money and moving it to tax credits instead of subs. Like, it's the same money moving around, right? Like, so it's a shell game. I think what you're hitting on, or I'm going to paraphrase what I think you're trying to say. There's no market for 6 people. It's going to cost you a lot of money no matter where it comes from. It's either going to come from you in premiums, it's going to come from the government and federal subsidies. It just costs a lot of money to take care of people. And it costs more money to take care of people who are probably sicker than average to start with. Who has to pay for it? Where does the money come from? That's why we have these policy discussions, right? There are different thoughts on that. But that's a good point. Yeah.
I know we're derailing your discussion here, but are you going to touch on single payer? That's kind of interesting.
I'm not, but I can. We'll see how much time we have left at the end. Single payer, the Canadian system, Medicare for all, right? We'll see. I may venture my toe in there a little bit. We'll see. The short answer is it's not a panacea either. It has its different problems and issues. All right, let's keep going. Another reason why premiums have kind of gone up in these markets, right? So this is one of those things where it's well-intentioned, but we have to be realistic about what it means. Another thing that the ACA did was that if you're going to offer a health insurance plan in the market, then you have to meet certain essential benefits, right? Like there's a certain minimum level of coverage that includes preventive services that weren't always covered before that have to be covered for those policies. Okay? Let's be realistic about that. What does that mean? If you are forcing insurance companies to provide a level of preventive services above and beyond what may or may not be included, what does that mean for premiums and what does that mean for the cost? It's going to have to be higher, right? So this is another thing that happened to those people who had a plan they liked but had to buy in. They had to buy in because their plan didn't meet those minimum criteria. And in the process of buying in, they had to oftentimes end up with more expensive plans because they included more that they may or may not have wanted. Right? So, but some people feel like this is a good thing because a lot of folks didn't necessarily want insurance plans that were skimpy. That's just all they could afford. So this was trying to design to make sure that those that were buying in, particularly those that got subsidies, the plans that they bought weren't, kind of janky or whatever. Like they were actually legitimate insurance plans. So there are 18 services for adults, 26 for women, 27 for children, that every plan had to cover at free or no cost, and that was just part of the package. So the idea was that you increase coverage. You don't just increase coverage, but you make it better coverage that covers preventive services at little or no cost. Why that? Why did they make them provide preventive clinical services at little or no cost? It should be a no-brainer for public health people. Because you want them to use it, right? Like you want me to take my kids to get their well-child visits and not show up when they're 5 with no immunizations and, pertussis or whatever it may be. You want people using services that will catch things early, that will keep them healthy for longer. You don't want these things building up. You don't want them festering because when you do show up, you show up in bad shape and it costs a lot more money to fix. So again, the idea, they're really trying to push this prevention paradigm forward a little bit by the way that insurance is paid for and covered. But the problem is that shifts the financial burden to insurers to provide it, which means that the premiums were a little bit higher because of that. So you have to be honest about that. That's an issue. Some people feel like that, doesn't need to be there. So here's the most unpopular part of the ACA. Is it the government's responsibility to make you have health insurance if you don't have it? Should the government be allowed to force you to have health insurance? So you, in your sovereignty as an individual, should you be allowed to say, I don't have to have insurance if I don't want to have insurance? We're not going to answer that question in here. We're not going to talk about that. This is not that kind of class. But that is why it's the most unpopular part of the ACA, right? Some people, it's not that they don't want to have insurance or wouldn't have insurance, but okay, I got to tell you, I'm like this. So my dad's a preacher, just so you know. And when I was a kid, I used to do all kinds of stuff that I shouldn't do. Why? Because somebody told me I wasn't allowed to do it, right? I'm wired that way, I'm sorry. I suspect that I'm not the only one. It's the same thing. It's like people would probably do it anyway, but whenever you tell me I have to do it, I'm like, hell no, I'm not doing it, right? Like, you're just not going to. And I think that's what you see a lot of the blowback around the individual mandate, right? Like, people don't like being told what to do, and they especially don't like to be told what to do by the federal government, right? That's the reality. I don't like it, right? I mean, that's not an uncommon reaction. So let's talk about this. Why? Let's go back to last week's discussion. Why is the individual mandate in the ACA?
Because the more people in them, that's how you can get the money. When there are more people that are healthy in the plan, that's how you can,
For the ACA to work, you're right. I'm going to rephrase it though. For the ACA to work, for the community rating scheme to work, everybody has to be in. You can't let people out. If you let the young healthy group out, the ones who are really upset about this individual mandate, you don't have young income for people who aren't really as sick yet to help offset the cost and bring it down for the people who are really sick and really need it. That's why the individual mandate is there. It's not because the government wants to tell you what to do. It's just because that's the only way that these market reforms will actually work, right? Like, that's just the reality of it. That's the only way it'll work. So it's called the individual share responsibility payment, right? Like, that's a very crappy word for saying you have to buy insurance. So here's the deal. This is the kind of stuff that makes me mad too. Well, let's just talk through it, and I'll think about whether or not I want to say that in a minute or not. So the way this works is like, this is all like federal tax return stuff, right? So nobody's going to come knock on your door and say, do you have health insurance? So when you file your taxes at the end of the year, they ask you questions like, did you have health insurance this year? Were you covered? Whatever. So it's 2.5% of your income. So if you take the bronze plan, the payment penalty is 2.5% of your income, and there's like a certain cap on it. So roughly it's about $700 for an adult. Absolute max would be like $2,000. So if you file your taxes, you don't have any, you guys, I haven't had to do this, but some of you may have already had to go through this and answer the questions, and I'm not really sure what they charged you. You might be able to tell me. But it's anchored against your income, right? So they're not going to you're not going to get charged $10,000 because you don't have health insurance, right? It's not a criminal offense. Like, it's not even a civil offense. All they do is don't give you a big tax return back that you may have gotten before. So they withhold it from your tax returns, okay? So, yeah, you may have to suffer a bit of a financial penalty, which is fine. But again, the whole idea is that you're trying to provide a financial stick to make sure that everyone enters the market, right? Because you have to have them in the market for it to work. Here's the key. Are there exemptions to this? How many of y'all think there are exemptions to the individual mandate?
They should.
How many of you think there are no exemptions to the individual mandate? Okay, there are all kinds of exemptions. So first of all, you have to file income taxes to even, so they can even find you to even think about charging you, right? What proportion of the U.S. population actually has to pay income taxes every year?
The ones with income.
I want to know your guess. What proportion of people that live in this country actually have to pay taxes when they're have to file taxes and pay taxes every year in April? Let me back up and ask you, what percent don't? Anybody want to guess? 40? 30? Y'all have smartphones. I'm sure somebody could Google it. 43%. 43% of people who live in this country don't even pay income tax in the first place. Now, some of it is that they have enough tax return, like they have enough exemptions to get them under it. Some of them just don't. They make so little money that you don't even have to file taxes. Okay, so right from the get-go, those that are extremely poor are really the ones that you were trying to get insurance to anyway. They don't even file taxes in the first place, right? So they're already kind of exempt from this. Yeah, so if you enroll during open enrollment, if you were only uninsured for a couple months, if you don't have to file taxes or meet the tax thresholds, right? So like even if you file taxes, like there's certain thresholds that you have to meet to be penalized. If coverage would have cost more than 8% of your family's income based off your income taxes, you don't have to pay it. That happens to a lot of people, right? Because premiums are high, especially for low-income folks. If your state didn't expand Medicaid, you don't have to pay it. Okay? So, are there some people who have to pay the individual mandate? Absolutely. Are those poor people? No. Right? Those are people who made enough money where they had to file income taxes legitimately, which means they probably had a respectable job, right? Maybe their employer provided, maybe they didn't, maybe they chose not to take it, maybe they didn't. But there are plenty of exemptions to the individual mandate, right? So let's have some honesty about that. What infuriates me, last year I was driving to work and listening to talk radio, and I was listening to talk radio, and this is an elected official that is the host of the radio show. And somebody called in, and they were all railing against Obamacare, and they're like, is there any way to get out of the individual mandate? And this particular person was like, no, to the best of my knowledge, there's no way to get out of the individual mandate. I almost wrecked my car. I was going to call into the show. Like a 10-second Google search is how I found that. Right, so 10 seconds on Google will tell you absolutely there are plenty of exemptions to get out of the individual mandate, right? So that's what I'm saying, like have some common sense, right? Like you can, if you know how to ask the right questions, you can find the answers pretty quickly, right? I mean, that's just laziness, Anyway, I seriously, I'm like, if I wouldn't have been driving, I was going to find a number and call in and say, this is the list of all the ways you can get out of it, right? But anyway, I didn't. I should have. Y'all, I'm sorry. This new bill just upsets me. I can't help it. And I'm being a little bit more facetious and saying a lot of ugly things that I probably shouldn't, but y'all just going to have to forgive me. I'm sorry. So, the other component is the employer-sponsored mandate. This is another one. How many of y'all heard Obamacare is going to kill jobs? How many of y'all heard that? Right? Yeah, because you're requiring employers to provide coverage, which means that people are going to lose jobs because they're not going to offer insurance. They're just going to get rid of people, things like that. So the employer requirement, right? The employer requirement only applies to companies that have more than 50 employees. Okay, so if you're a small business that has 5, 6, 7, 8, 9, 10 folks working for you, doesn't apply. Employers that have 50 or more FTEs. 95% of those companies already provide health insurance for their employees. This part of the ACA affects 3.6% of all companies operating in the U.S. Think about that for a minute. 3.6% of companies does this apply to. Think about all the companies that are active in the U.S. Most of them are already providing insurance anyway, right? So if they don't comply, there are fees involved. It's like a $2,000 per month FTE, minus the first 30, blah, blah, blah. I mean, there's like a complicated formula. But 96% of all employers in the U.S. have less than 50 FTEs. It doesn't even apply to them in the first place. Now, let's be honest. I don't want to be accused of having the same intellectual dishonesty as I'm accusing others of. There are folks who lost their jobs and insurance coverage because of this, right? It's roughly, I don't know, I think it was like 5 million or so. So there was a net positive, right? Some people lost their jobs, but a lot of folks gained access to their jobs because their companies did the right thing and, provided it. So yeah, I mean, there were some folks who did lose their jobs, right? But again, this policy, this lever of the policy affects less than 4% of all companies operating in the U.S. So keep that in mind. So through this one, you had about 10 million that gained coverage, about 6 million that lost coverage. So again, that 6 million that lost coverage, I mean, that's less than 3% of the labor force, right? So I don't want to dismiss that, right? Those are real people. Those are folks who had a job that lost their job, that lost their insurance coverage. Like, that's not good, right? Like, that's bad. But if you net it out, there was a net gain of, 5, 6 million, 4 million, 5, 6, whatever. I've got it written up there, 4 million. So when it all settled out, you still had 4 more million people that gained insurance through this policy than lost. So I don't want to minimize or downplay the significance that had on the folks who lost their coverage, but from a policy perspective, it was a net gain, okay? One thing that you have to worry about when it comes to this is something called crowd out, right? What is crowd out? If you're an insurance company and you're going to face a financial penalty if you don't offer coverage to your folks, maybe you let them go, maybe you drop them to part-time, maybe they were working full-time, but you drop them to part-time and tell them to do what? What do you tell them to do if you drop them to part-time? Who said Medicaid? Yeah, you all can read, right? Like I've already got there. Guess what you have to worry about, right? So a lot of companies don't want to bear that cost themselves, so they'll lower hours, reduce benefits, and just tell their folks to go apply for Medicaid because they might be eligible for Medicaid. This is treated like low-income workers. I don't want to list any employers, but there was a really big one. It's very famous in the U.S. that was guilty of this for a long time. So they're shifting the burden on folks. What?
Was it Papa John's? Didn't that have to do with the health insurance?
It wasn't Papa. That's the one I'm thinking of.
Wasn't there some sort of scandal?
This is a place I refuse to go. I've been there one time since I moved to Johnson City.
Walmart.
I'm not saying it. But anyway, that's the thing is like you can hire folks in low-wage jobs, not offer health insurance, have them go sign up for Medicaid if they're eligible, right? So employers, it's kind of the stuff that bothers me, right? Like everybody wants to beat up on public sources of insurance, but when it works out to an employer's advantage, we kind of take for granted those things are there. But anyway, that's what crowd out is. So employers drop coverage, push employees to Medicaid. So you see a big, push. You see a lot of increased enrollment in Medicaid around this kind of stuff. Did Obamacare kill jobs? Who thinks it did? Who thinks it didn't? Right? So this right here was when the Affordable Care Act went into place. These are private sector jobs lost, private sector jobs added. So at least in the first 5 years following the ACA, is the ACA killed jobs? No. Is it added jobs?
Yes,
It's added jobs. Where are these jobs being added?
private.
So you got the recession that's over and the economy's moving forward. There are a lot of healthcare jobs added under the ACA, right? Like this is a good time to be getting a public health degree or a health administration degree because this stuff is complicated and providers, hospitals are trying to figure it out. So there are a lot of jobs that are all, being added to the economy trying to deal with figuring out these payment and practice reforms we're going to talk about in a minute. So anyway, my point is, again, these are the things that, I'm fighting a losing battle, I know. I need you to understand this stuff, right? So when you flip on the TV and you see folks railing against Obamacare and you hear things like Obamacare is a job killer, it's crushing the economy, right? 10 seconds in Google can tell you that's not true if you know where to look. Right, so that's the kind of, I need you all to understand this, right? Like this is important to me that you understand. A lot of the stuff that you hear about the ACA is just not true. It's just not true. It has problems. It has problems that need to be fixed, and we're talking about those. But a lot of the stuff that you hear, let me back up and say it this way. A lot of stuff that you hear, there's no empirical evidence to suggest that that is true. I don't want to say that's not true because it could very well turn out to be true in 5 years, but at least in the first 5 to 7 years, most of what you hear, there's no empirical evidence to suggest that that's the case. Anyway, this is the same thing. Point being that job growth, unemployment, all those things are strong. They're as strong as they've ever been. All right, Medicaid expansion. We're getting close to giving you all a cognitive break where you can maneuver around for a minute. Just hang in there with me.
Sorry, since you are in the policy research, would that be a better way to communicate these benefits better to the public? So I think the vast majority of people don't understand this technical stuff that you're telling us. We are educated, that's why we're whizzing along. But a lot of the voters, a lot of people that are congressmen represent, they don't get this.
Yep.
How do we better communicate?
So let me rephrase your question so they can hear you back. So I'm going to paraphrase his question. What he's saying is Dr. Hale's doing a great job explaining this stuff, and it makes perfect sense to me. That is what you were saying, right? How can this be better communicated with the general public so that other folks can understand what's happening and be an educated consumer and make better decisions about this moving forward? Is that what you were saying?
That's absolutely correct.
You guys tell me.
I mean, the alternative to the health department
So I tell you this, where the ACA messed up is when they rolled it out. When they rolled out healthcare.gov for the insurance sign-ups, they did not do a good job with that.
Yeah.
Right? Like the thing was shutting down. Now I will say that there's evidence that people were intentionally trying to run worms and viruses to make it shut down, but that's a different issue. The problem is that I don't know the answer to this. Like this is why I get so aggravated and why I'm saying a bunch of stuff that I shouldn't today. I think that you have a lot of loud voices on both sides that are giving misinformation in both directions, right? Like some people are saying good things about the ACA that aren't true. And some people are saying bad things about the ACA that aren't true. And the rest of us are kind of caught in the middle trying to figure out like what's true and what's not. I have a terminal degree in, health services and management policy research kinds of stuff. So for me, I can hear something and say, okay, I know where to go find out whether that's true or not. Right? But that's what I do for a living. Is the average person going to do that? No. And even if they could, would they be able to understand it? And I don't know. I don't know the answer. I mean, that's, part of why I've stopped being so silent about it, quite frankly, is that for the longest time, at least me personally, things like healthcare are inherently political, whether we want to, think about them that way or not. They're inherently political, and why healthcare is a wedge issue, I have no idea. But it is. So for me, I typically don't speak out on these things because I'm sensitive to the people around me. I have friends who feel very differently than I do about this, and I don't want to say things that I know would be offensive to them or insult their intelligence or act like they're not smart enough to figure this stuff out. So I don't say anything. Now, I have to listen to all their ridiculous opinions that have no backing whatsoever, but that's fine because at the end of the day, friendships and collegiality and relationships are more important to me than winning an argument over healthcare policy. So I don't say anything. However, what I'm starting to realize is that that's a problem. Because people who do understand these things and can speak to them in a way that's not threatening but provides general information that's supportive need to do that more often. And it needs to be in the public space, even though people get mad when they read it. It is what it is, right? Like, you can only, if you care about something and it's important to you, you can only be quiet for so long. And there are times to say things and there are times to not, and there are ways to do it and there are ways that you shouldn't do it. No matter what happens with all this, at least for me, this is one of those times where you just can't be quiet anymore, right? Because the plan that's on the table right now, it's not good. Like, it's not good. Like, that's the only thing I can say about it. Like, it's not good to the point to where if you have research that shows that for every 830 folks that gain insurance, you can expect to have one death averted. The reciprocal of that, right, like this is just data, the reciprocal is if you take insurance away, you can expect that people are going to suffer as a result. That's not something I want to be quiet about, personally. So for me, that's a little bit of a tipping point, right? Like, at some point somebody's got to speak up and say something. And it needs to be people who are not trying to push an agenda. It needs to be people who are trusted, right? Even though academia tries to get discredited because we're all ivory tower or whatever, elite liberal academics. I grew up in eastern Kentucky and central Appalachia. You can call me a liberal elite if you want to, but I can tell you I grew up dirt poor in the middle of nowhere. So the reason I care about this is because I've seen what happens when people don't have access to care. I've seen what happens when people don't have insurance. I've been through it in my own family. I've seen it over and over and over again. It has nothing to do with being a liberal elite or an academic or whatever. To me, it's an issue of ethics and morality. But that's just me. That's my career, right? So not everybody feels the same way. That was a really long answer to a very simple question. To say, I don't know what the answer is. I don't know how to get accurate information out to the general public in a way that's understandable, other than saying that people who can do that and have the skills to do that and can do it in a non-threatening way that's designed to produce dialogue and not be condescending need to start doing more of it, which is why all my friends are mad at me on Facebook. I'm not being ugly, I'm just stating facts. Like, it's amazing how when you just put a piece of data in front of somebody, they just go ballistic. And I'm like, all I said was this. Like, how did you deduce that from this? But anyway. All right. Medicaid expansion. Y'all, this is a bad time for me to be giving a lecture on this. I'm sorry. Bad time. I'm still processing myself.
It's an exciting time, is what I say, to be doing public health, because it's so dynamic, right? Like, the bills that came through last semester, it was like whiplash trying to process them. And you guys are going to leave here and be acutely aware of healthcare reform and the politics around it, and you're going to be able to speak and go into your communities and hopefully not have fights at Thanksgiving. But, you know, maybe drink a glass of wine and try to ignore your mother. But, you know, this is a really exciting field to be in. Not every field we have to, like, scrap whole lectures and redo them year to year. I mean, this is where we are right now, and you guys are the people who are going to communicate. And Dr. Baker teaches a health communications class. You could probably take it as an elective and learn about those skills and learn from what really went bad. Obama, as a president, was an academician too. Very, very smart. Not the best communicator of his policies, even when they were good ones. And that really did not help him out or help the Affordable Care Act in the long run. Because if you have short, little, you know, job killer, that resonates longer than something that was eloquently said, but
Let me,
not easily.
yeah, we've been together 2 weeks now, right? I mean, is that enough to be friends?
Yeah.
Are we friends now? I'm not, there needs to be an element of like, that's the word, take a boundary, but you know, just, you guys know what I mean. Yeah, we're friends, we spend a couple hours together now. I went through my PhD program as a conservative Republican. Absolutely. I went through my PhD program as a conservative Republican, so over 30 years of my life, I spent thinking that that was the way that you should do it, right? Like, you know, personal responsibility, you know, my thing about taxes where I said that 43% don't pay taxes, the reciprocal is that the top 1% of income earners pay over half of the income tax, right? So that was the kind of stuff that I used to go into my classes talking about, right? Because again, we've already established that I'm a little bit of a nonconformist and, you know, like to say that. I went through my entire PhD program until the very end, thinking that things like this Graham Cassidy bill were the solution to the problems of healthcare. Give it back to the states, personal responsibility. Why should I have to pay if you don't want to get off the couch and exercise? Like, that was my mentality going through a PhD program. What changed? You guys don't know. You won't know that.
Someone got sick in your family?
No.
Oh, sorry.
No.
Data?
Heaven forbid.
You met people who are different than you.
That's one. Right, so I've been thinking about this a lot, right? I'm really upset about this healthcare debate stuff, if you can't tell. I was thinking about this in my PhD class. Let me back up and say it this way. I get really defensive about attacks on academia and the way we operate, right? So I'm being a little bit forthcoming here and putting my cards on the table and saying things I shouldn't. But most of the time, I think we try really hard to expose you to a variety of information, teach you critical thinking skills, and let you come to your own conclusions. Right? In my PhD program, I had to read articles from the Heritage Foundation. Right? I'm not going to comment on how good they were, but I had to read them. We had to read articles from Senator Bill Frist, who's a Republican on healthcare reform. Right? My comprehensive exam in a PhD program was to compare and contrast Obama's healthcare reform policy against leading Republican policy. Right? There were no lectures in my PhD program. Right? I never had a professor doing what I'm doing to you right now, telling you how ridiculous something is. Right? You read a lot. You're exposed to a lot, right? Here's the thing. The whole time you're doing this, you're learning how to do research yourself. Okay? I'm going to recruit him into our doctorate program here. You're learning how to do research yourself, right? You start off knowing a little bit, but you learn, okay, this is what a good study design looks like. This is a good analysis. You learn what good research looks like. And whenever you have to complete your assignments and you start working on things and you get assigned all these readings, right, you can see what's good research and what's not. What can be backed up empirically, what's not backed up empirically. And over time, this is just my own personal story. I think it's okay to share. Over time, I could only do mental gymnastics around what was so clearly obvious to me for so long, to the point to where it's like I had to just be like, I'm wrong. I cannot find any empirical evidence to back up what I think I know in my head. And that's why, sorry, I'm getting really philosophical here. That's why I wanted to go into academia and be a professor. That's why I want to be here talking to you right now. That's why I want to do what I do. Because if you don't think that education has the ability to transform your life, and I'm not saying that, like, you know, going from Republican to Democrat is like, you know, life transforming, but the ability to be able to think critically, think for yourself, figure out how to find information, sort through it, as messy as it gets, and come to your own conclusions. If you don't think that has the power to transform your life, then you don't need to be in college. And that's why I want to be here, and that's why I want you to be here, and that's why I'm glad that all of you were sitting here. Right? So the point being that this is not something that's like, this is new to me too, right? Like arguing on behalf of the ACA is not something I would have done for 35 years of my life. But personally, like there's only so much that you can look at and look at the evidence and be like, I can't get there. That's not what the evidence suggests. Like you can only do that for so long before you just have to let it go and just admit that you were wrong. And like that's what I had to do. So that's me. Now, are there Republican policies around healthcare that I think have utility? Absolutely. There are. It's not the one that's on the table now, but, you know, consumer-directed health plans, right? I think those are good tools for certain groups of the population, right? I'm not opposed to a federalist model. I do think that all policy is local and that, to some degree, shifting responsibility for that to the states is a good thing. Do I think block granting Medicaid is the way to do that? No, I think it's a horrible idea. But there are things about alternate policies that are potentially beneficial. What we've got to figure out is how to freaking sit down across from each other with respect, mutual understanding, and dialogue and say, we may disagree on some things here. This is what I've got on the table. This is what you got on the table. What's the best that I can pull from you? What's the best that I can offer? And put those together into a bipartisan healthcare bill, right? Like you would think that that would be common sense because there are things that Republican plans have to offer that could be beneficial. There are things that Democratic plans have to offer that could be beneficial. That's where we need to get to. That's what we're trying to get to. And that's why this whole thing that's happening now aggravates me so much because it's none of that. Sorry. I'll take that as agreement. It's none of that, right? Like there's no, you know, there were bipartisan efforts underway to try and craft a comprehensive bill that was both Republican and Democrat. And then this latest push, the whole thing just blew, like it just stopped because, anyway, like that's the thing, like, listen, Democrats are guilty of this too, right? They pushed Obamacare through without a single Republican vote, if I'm not mistaken. Right? So they crammed Obamacare down the Republicans' throats, just like the Republicans are trying to cram this new bill down the Democrats' throat. Right? This is a bipartisan statement. Both of them are wrong. Now, there was a lot more vetting, a lot more meetings, a lot more subcommittees. Like there was a lot more of that kind of stuff with the ACA. And ultimately, they just went ahead and did it anyway because they weren't getting any cooperation. But they're not even trying that stuff with the Republican bill. Like, there's not even a debate. There's no committee. There's no nothing. It's just, we're going to pass it because we have 50 votes. And we changed the rules to get the 50 votes in the first place, but that's another issue entirely. Yep.
Yes, sir. Isn't that a problem that policies are becoming more partisan?
Absolutely. It's a big problem.
Like, there was a survey they did after the election. Many people said because of marriage, So I think that's the big problem for
Y'all stay with me. We're almost there.
I think that another problem is that the people that stand for the MPs are like the loudest voice in the, because profit is like what drives America. So they're like the loudest voice and they're the ones that can push propaganda and they have the money to push the propaganda.
Yeah. Those are both valid points. Let me just say this, and I'll answer your question. To some degree, I feel bad for the way that I've let this deteriorate on my own part. And I feel bad that I kind of let my own personal stuff spill into this lecture. But quite frankly, at the end of the day, this is an academic institution of higher learning. We need to be able to have these type of discussions in here for mutual benefit and learning, right? Because at the end of the day, when you walk out of here and you go try to talk about healthcare policy, it's emotional, it's political, it is what it is. And I don't think, although I do feel a little bit bad because I feel like I've neglected my responsibility to be neutral in presenting this, but when it comes to something like healthcare reform, you can't get away from the fact that it's political and that it's emotional. And, we can pretend that's not the case and skirt around the issue, or we can just address it head on and talk about it like adults, which is what I think we're trying to do here. Yes.
Thank you very much, sir. I want to use my country's issue to summarize this, which I fully understand what you're trying to say, and which is why we are here, but not everybody can be here. And don't blame people also that are giving the counter arguments because they don't have the information. What is happening in my country? There are two sides. One, maybe right or wrong, it's not for me to call. It is for those who don't have the knowledge or probably who are no more informed that take sides. We are of higher learning, we get it very well. In my country, there are a lot of propagandas. Maybe it's true, maybe it's not true. Somebody comes from one side and gives it to be true. The other person comes from another side and gives it to be true. You who quite smart can sit down and verify which side is true. Probably no side is true, probably both sides is true. But those who don't have the chance to take it hook, line, and sinker, and act, and there will always be this disparity between both sides. And that's why we're in this class trying to figure it out, and we cannot figure it out. But we can just, because of the information we have. So I get what you're trying to say, and I understand it.
Sign for president.
I need to be quiet now and just sit down. That's a good point. I don't really know how to transition back to the lecture from that. Excellent point. So anyway, all right. What time is it?
It's 2:24.
Alright, so, that was a lot of transparent emotional stuff, so let's dial through this real quick, which is what we're supposed to be covering. So Medicaid extended eligibility for people who were at 138% of the federal poverty level, so that's about $28,000 for a family of 3. So expansion would reach about 10 million folks. I think what it would say was sitting about 9 million right now, so it got pretty close. A lot of states already covered at a higher percent of FPL, so it wasn't really a big deal. A lot of states already covered pregnant women and children, so for some states it wasn't a huge leap. The big issue here is that the Supreme Court, the states challenged this, right? And the Supreme Court ultimately said that the mandate for states to expand Medicaid, even though the federal government was paying 100% of it for the first few years and it dropped down to 90%, was an undue burden on the states. Therefore, the states should not have to expand Medicaid, left it up to the states. So here's the big problem with that, right? Besides the fact that folks didn't have access to insurance, there was a coverage gap. So states like Tennessee, South Carolina, states that didn't expand Medicaid, so you had your really, really, really low-income groups that are going to qualify for Medicaid no matter what. You had your other group over here that was at least 100% of federal poverty, up to 400% that could get subsidies through the market. But there's this whole group over here that are just below poverty that weren't poor enough to qualify for Medicaid but didn't make enough for the subsidies to kick in, that were caught in a coverage gap. They had no option. When I say no option, I mean no option. They have no insurance, right? So that was an issue. So there are about 5 to 6 million folks that got caught in this, and again, they're only in states that didn't expand Medicaid. So that's just more of the same type of information. So at the end of the day, The ACA extended coverage, so 22.8 million people gained insurance. Not all of those were previously uninsured. Some of those were folks who had insurance but got a better deal. About 6 million lost coverage, so there was a net gain. These are folks who didn't have insurance before the ACA that got it under the ACA right at 17 million. So that's kind of where it stands right now. So it's not the 32 million that was originally projected. A lot of that has to do with Medicaid non-expansion. A lot of it has to do with the fact that folks aren't really even rolling in the private market for various reasons. But it's not reached its full capacity or its full projection. But 17 million people is not an insignificant number of folks that now have insurance that did before. So, kind of going back to this, just restating what we've already looked at. That's where it stands. Can't remember if I showed you all this. Big decline in uninsured. The marketplace is a big deal. Like a lot of folks have, gained access through the market. Medicaid is obviously a big one. All right, so y'all hung with me? Yeah.
So with the Medicaid expansion, I was wondering if there's a lot of emphasis with the data saying how many people have gained coverage and also the projection of morbidity loss with the Massachusetts bill, but is there any analysis of how health has improved in various states due to the ACA?
Yeah, that's a really good question. So how is mortality and health, like whatever metric we want to look at, how are states faring since the passing of the ACA? So the short answer is there's not enough time has gone by to look at it, right? So the ACA was phased in. There are things that occurred in 2011. There were more things that got phased in 2013. 2014, I think, was the first year where you see most of the components of the ACA fully implemented. There are a lot of issues on the cost side that are just now, starting to come in. So the short answer is there's just not been enough time to look at it. And when we do look at it, it's going to be a complicated mess because of all the, some states expanded Medicaid, some didn't. Some markets have done this, some haven't. It's going to be really hard to look at. That's the advantage of the Massachusetts study, because it was very, it's a small state, right? So it was very confined. Everything was very specific. It'll be a little bit more messy when we look at it nationally, but, I can tell you the best and the brightest will be all over trying to look at it nationally. Well, the best and the brightest on both sides. There'll be people trying to repudiate it, people trying to support it, but, it is what it is. All right, so that's the enhanced access side. So that's the first part. Like it or not, we still got a whole second part that I'll probably move a little bit quicker through, maybe skip some stuff. That's the access part. So market reforms were a big part of that, trying to make it affordable. We'll talk about some of the issues that are kind of undermining that in the second part. But increased access through market reforms, through Medicaid expansion, those were the big ways in which insurance was pushed out to folks. Over 20 million have got in under the ACA. About 17 million of those had no insurance prior to the ACA. So that's kind of where we stand on the ACA right now. So, 5 minutes. Do some burpees, take a lap, get a drink of water, go to the bathroom, process all that information, and then come back and we'll talk about the cost side.
So what is this? Stop it. It's from the farmer market. Farmer's market? Can I take you? I love your hair. Oh, is it? I want to say it's in October. Is that true? It's like just like a weekend, I think. I have all sorts of beers.
All right.
Oh my God.
How come nobody takes me up on my offer?
October 13th. Yeah.
You go first.
All right. We don't get rolled soon. I wanna shortchange you your 2 hours and 50 minutes. Give it another second to folks to sit down. Roll in. Alright. So, are we friends now again?
Always.
I have to tell y'all, I had to get that off my chest.
Let it go.
I did. Like,
Let it go.
like I had to articulate it in one big blur, right?
This is
Like,
no
so,
joke zone.
Yeah.
You feel better now?
No, probably not.
I feel a little bit bad because I feel like I was a little bit too interjecting my personal opinions too much. But I freely acknowledged it, so, and told you where it was my opinion and not whatever. So you can
Hey, it's fine. It's cool.
you can agree or disagree, and you're free to dispute or repudiate any point that I make. However, it has to be done with empirical evidence and not conjecture. That's my only rule. Alright. So here's the deal. Increasing access is the easy part. Right? You can change policies and you can change Medicaid thresholds and you can do things like that. You can create access as soon as it's signed by the president, right? Like it's an immediate effect. What happens, right? Let's be realistic about this. Everything in healthcare is about trade-offs, right? Like if you're going to cover everybody, it's going to cost you money to do it. If you want to save money, you're not going to be able to cover everyone. Everything's about trade-offs. It's about what you're willing to give up and what you're willing to get, right? And like we all have different thresholds of what that looks like. It's easy to grant access. It's easy to provide access. But if you do that, you are going to increase costs. Like there's no way around it. You can argue that people will be more healthy and that'll save money in the long run. As a public health person, I think that's true, a little bit harder to measure. But at the end of the day, you are going to increase the cost of the healthcare system exponentially by adding folks to insurance. Why? This is not a hard answer. Because they're going to use it and they're probably sicker than the average person. So that's an issue. So the ACA, the first part of it was increasing access because, you know, that's just what needs to be done. At the same time, the ACA tries to put provisions in place that help control healthcare costs, right, collectively throughout the entire system as a result of the ACA. So we're going to talk about those policy buckets that are out there that are trying to control costs. And I'll just tell you, a lot of them are trying to control costs by increasing the value of the services that are being provided, right? So that's really what's happening here. That'll make more sense in a minute. So they're attaching reimbursement and payment in healthcare to the quality of care and the outcomes that it produces, not just the fact that you're doing it, right? Like that's a fundamental shift in the U.S. healthcare system. So the first policy bucket, right, like they're trying to control costs by having managed competition in the marketplaces that we talked about earlier. Keep premiums low by having multiple insurers offering plans. Enhance access to preventive care, which in theory would help folks maintain more health and well-being for a longer period of time. So trying to control costs that way, right? So through managed competition in the marketplace, you know, better preventive health, things like that. So that's one area that we'll talk about. It's not particularly working very well, but we'll talk about that at the very, very end. The big one I want to focus on are payment and practice reforms, specifically around Medicare. So this is a shameless plug. I'm going to put my hands above the table. If you want to learn more about payment and practice reform and population health management, you can take my class as an elective, right? It's 6310, population health management. We talk a lot about the payment and practice reforms, and we talk a lot about how you actually go about improving population health from the perspective of healthcare systems. So I'm going to pull from some of that material here because I think it's directly relevant because it all The whole first part of that class is how the ACA is changing payment and practice reform. Right. So like that's the whole first part of the class. So if you do take that class, you still have to come to the first 3 weeks just because you're going to get a snippet of it here. But the short of it is they're shifting from volume to value. They're not paying for health care just because you provide somebody a service. They're trying to attach every payment to some type of quality benchmark, some type of value-based reimbursement. So attaching payment to quality, if you want to change the behavior of healthcare delivery, if you change the way that it's reimbursed, you will create action very quickly, right? Because people are very smart, they're not going to lose money, they're going to figure out how to make it work. So what the ACA did, like this is in the ACA, and I'm going to show you the actual ACA picture in a minute. The ACA put out new payment and practice models that they wanted to see implemented in the healthcare system as a result of this policy. Now, these were around before the ACA in targeted areas. The ACA just kind of took the best of what was working in this area and put it under one umbrella and put funding behind it. So these are not mutually exclusive, right? So I want to present them as like different programs, but they're all interrelated. Like they're all around this shift from volume to value. Multiple complementary approaches. So they're testing new models of healthcare delivery, right? So they're saying, we're going to give you some money, and we want you to figure out how to make it work, right? That's good, like using states as incubators, things like that. And they're investing heavily in system-wide improvement. So whenever I said earlier that the ACA is not really a how-to manual, it's more of a what-to manual, this is what I mean. So I guess I should have told you what these things meant before I put their abbreviations up here. So value-based purchasing is a program in Medicare where it's exactly what it sounds like. They're paying for health care based off of value. There are 4,000 words in the ACA around value-based purchasing, and that describes 3 different programs. Okay. Innovation models like these state incubator programs that I just mentioned, 2,300 words. Accountable care organizations. You guys heard those? Like that's like the juggernaut of healthcare reform right now. Accountable care organizations. Sorry. 1,500 words. Yep. I didn't get it. Accountable care organizations. Right? So this is what's driving a lot of the change in the healthcare system now. 1,500 words in the ACA. Okay? Your issue brief is probably going to be more than 1,500 words. Right, and those are supposed to be short. Point being, they don't give you a lot of meat in the ACA to help you figure out how to do it. They just tell you what needs to be done. A lot of this implementation falls to federal agencies. The big one around healthcare reform, they all fall under the Department of Health and Human Services. A lot of this is really falling on the Center for Medicaid and Medicare Services, which is called CMS. So when I refer to CMS, I'm talking about the federal agency that all this stuff got kicked to, and they're responsible for Medicare and Medicaid. So, in case you haven't figured out, this is complicated. And, like, I'm a visual learner, so I have to have a picture of something like this before it makes sense. So the way that I would think about this is that CMS got kicked all this stuff from the ACA, right? Like there are things that CMS has autonomy to act on now as a result of the ACA independently. There are things that they've been given money to prop up and implement. But either way, they're responsible for a lot of stuff, and it gets very confusing. So the way I kind of think about it is, CMS, in the ACA spelled out this concept of value-based purchasing. Like there are 3 programs that we'll talk about. The CMS, they have the ability to act on that regardless. The Affordable Care Act also told CMS that you're going to create this Center for Innovation, Center for Medicare and Medicaid Innovation. So you have CMS, you're doing all this other stuff. We want you to prop up this innovation center while you're at it. And this innovation center is going to fund state innovation models where you're giving money to states for demonstration projects where they're trying to figure out how to braid sources of funding together and provide better care. And you're also going to fund accountable care organizations, which is we'll talk about in a minute. And at the same time, We're also going to give you money to push patient-centered medical homes forward. And those are standalone programs, but they're also being used in accountable care organizations. They're also being used in state innovation models. So when I say that they're all different, but they're the same, like that's what I mean. Like they're just a handful of things that are kind of circulating out there. And they're all designed around trying to do this. Better health, better quality at lower cost, which is a very ambitious thing to try and do. So CMS is trying to get 90% of all their payments linked to some type of quality or value metric. Like that's their goal. Right now they're at like 40, 50%. So again, the idea is that what? If you want to control costs, don't structure reimbursement around making costs worse, right? You need to structure reimbursement around trying to reduce costs. And that's what's happening here. The idea is that they're trying to structure that reimbursement around delivering quality of care that saves money and is more efficient, right? So that was all in the ACA. So these innovations, like they're already said this, I'm not going to go into it. So let me talk real quickly about these programs. Again, these are all, I think I took those slides out of there, but these are all specifically listed as subtitles in the ACA on the controlling healthcare cost side. So CMS, pay for performance, state innovation models, accountable care, patient-centered medical homes. So pay for performance, CMS, there's a garbage can right there. Did you guys know that? So one of the things CMS is doing is hospital readmission. So if you are a Medicare enrollee and you're admitted to the hospital for whatever reason, when they let you go and discharge you, if you come back to the hospital for any reason within 30 days, Medicare gonna pay that?
No.
Ooh. It doesn't have to be the same hospital, it can be a different hospital.
Medicare won't pay for it, but you still have to pay. You have to pay for it out of pocket.
No, the Medicare beneficiary doesn't pay for it.
Okay.
The hospital is not gonna get reimbursed from Medicare for the second readmission.
Okay.
Right? That's not exactly true, but that's the gist of it. I'll tell you why it's not exactly true in a second. Right? I'm jumping the gun here. There's something similar around hospital infection reduction and specifically around value-based purchasing. The common theme here is that what Medicare is doing, they're looking at these metrics, right? They're ranking you against other hospitals, and they're adjusting your reimbursement accordingly. So think about that. Right, let that sink in for a minute. So let's talk about this one. So this hospital readmission is not for everything. So I was being a little bit facetious and jumped the gun. There are certain conditions that they're monitoring. Heart attack, heart failure, pneumonia, COPD, hip and knee replacements, bypass surgeries. Right? Those are the ones they're looking at. They're looking at readmission rates specifically for those conditions. Right? If you have a higher than average readmission rate relative to all the other hospitals, then you're going to get a reduction in your Medicare payment across the board in all admissions. Right, so they're using these as kind of like a higher level metric, but that translates to you're not going to get reimbursed at the same level for everything that you do that relates to Medicare. Does that make sense? Right? So that can be up to you.
Doesn't that lead to doctors kicking patients out, firing their patients?
Firing their patients?
Yeah, if they're not following the suggestions of the doctor, things like that, then
I think it's the opposite.
It's opposite.
So if you know that you're going to get penalized if your patient doesn't do what you tell them to, what is your incentive as a healthcare system? It's not just a doctor. This is a system-wide issue. What's your incentive? You're going to do some transition planning. You're going to make sure they find their way back to their primary care physician in their community. If they don't have food, you're probably going to try and connect them with social support so that they can get. You're going to do whatever you got to do to make sure that they follow your instructions, because you can't stop them from coming to your. You can't stop them from coming to your hospital if they have a heart attack. Like, you're not going to have a choice over that. But what you can do is make sure that you transition them back into their community with the support around them so that they don't come back in 30 days. right? That's what population health management is doing. A lot of the initiatives that are coming from this are designed around exactly that. So I mean, on the physician side, when it relates to some other components, that reimbursement issues that might be coming up, you're exactly right. So if you're a physician and you know you're going to get penalized in reimbursement if your patients don't meet certain quality benchmarks, right? If somebody refuses to stop smoking and refuses to do whatever you ask them to do, you may just be like, I'm not taking you anymore. You may just be like, I'm done. You know, that's a legitimate, but that's more on the outpatient primary care side, right? Not so much the hospital. So up to 3% of your Medicare reimbursement is at risk, okay? So if you're not performing well, you can lose up to 3% of your Medicare revenue. Now, Medicare revenue is a big component of hospital margins, right? Hospital margins are already razor thin to start with. You know, about half of all hospitals are already operating in the red. Average margins are like around 4%. Like, that's a big deal. You lose that Medicare reimbursement, you're going to be hurting. In 2017, that was about $528 million that hospitals lost because of their performance around this metric. This is interesting. 80% of all hospitals were penalized at least something. Think about that for a minute. Now, less than 2% had the max 3%, so a lot of them got dinged a little bit. It's kind of within this margin where it didn't really cost them, it was kind of a wash when it was all said and done. So, let's go back to our comment here about how do you make sure these folks don't come back to your facility. So there's some research around this, right? So guess what they found? If you are probably help people. If you don't get this right, I'm gonna walk out of here. Not really, because I had to finish the class. But what did they find? Well, they looked at who was at greatest risk of coming back to the hospital and being readmitted. You all can read, right? Like the hospitals that got penalized the most are the hospitals that took care of a disproportionate number of low-income Medicare beneficiaries. Think about this. The hospitals that are getting penalized the most financially as a result of this program are the ones that are in the most vulnerable communities. Right? What they found is that these enrollees, they don't have the community support, they don't have the support of their family, they don't have the support that's necessary when they get back home to stay out of the hospital. Right? Now, in Medicare's defense, let's get this stuff, we don't have time. So in Medicare's defense, I think I've got that up in a minute. I'm gonna table that for a second. So what you see, like this is when the Affordable Care Act went into place, right? These are 3-year rolling averages for number stabilization. I don't go into why they do that. But you can see that the rate of readmission immediately following the ACA went down, right? They know that they're going to get penalized financially if they come back. You're darn skippy they were doing something to figure out how to not make that happen. And you see very clearly a decline in rates for heart failure, heart attack, and pneumonia on readmission. So when I say when you tie reimbursement to services, you'll get change. People are going to figure out how to not lose money. Okay, so some issues, like going back to the issue I talked about, and starting in 2019, they figured out very quickly it's not fair to look at all hospitals in a big distribution where you're comparing the ones that are taking care of a lot of low-income Medicare versus the ones who aren't. So they're actually going to put you into peer groups. I suspect they'll do some type of matching where you're only going to be compared against hospitals that are taking care of the same type population that you are. So your distribution and your payment will be attached more to your performance against like hospitals, not all hospitals. That's a good thing, right? Like they're adjusting. They see something in the data, clearly they adjust. Yeah.
Are they gonna do something for private versus public or profit versus non-profit hospitals?
Okay, so this applies to all hospitals that accept Medicare patients, right? So in theory, a hospital could not accept Medicare if it was a private hospital, but Medicare is a cash cow for hospitals. Old people go to the hospital. Another issue with this, like going back to this, is I don't want to get too far into this. I can't help it because I'm a little bit of a nerd. That distribution is always shifting, right? So you could perform very well over here and make marginal improvements, but the whole distribution shifts, and then like 5 years later, you're behind everyone else, even though you're still as good as everybody was 5 years ago. So the goalpost is always shifting, so that creates some issue. But anyway, those are measurement issues that can be worked out. They're on top of it. The hospital infection program is the exact same concept, right? Like if you have excess rates of infections, they're going to reduce your payment. When this went into place, this is fostering a lot of quality improvement within hospitals. I suspect that some of you may end up doing that type of work in your practices and things like that. They saw a 17% decline in hospital-acquired infections almost immediately. So again, tied to reimbursement, you're going to get an improvement in quality. Now, let me make sure I'm tying this back to the ACA. These are all programs that were funded and implemented under the ACA to control cost. Okay, this, right, is controlling cost because why? People aren't coming back to the hospital. They're not being readmitted for things they shouldn't be admitted for. Same thing for hospital-acquired infections, right? So I give you an example. My mom, she had to have hernia surgery. This was, I can't remember how long ago it was, because I'm getting old now. I think I was young enough to where like I went home and helped take care of her for a little while. So anyway, my mom was in for hernia surgery, routine hernia surgery. Comes back home, like doesn't get well, gets sick, has an infection, goes back to the hospital. Right, they give her some antibiotics, send her home, and tell her you'll get over it. She doesn't get over it. She goes back a week later and spends a week in the hospital with a hospital-acquired antibiotic-resistant infection. So a routine hernia surgery, which was like in and out, ended up costing the cost of the hernia surgery, plus the cost of the ER visit because she was sick, plus the cost of a week in the hospital because she had an antibiotic-resistant infection they couldn't get rid of. That's a hospital-acquired infection, right? So that surgery that she got an infection from cost a lot more money. So again, controlling costs. If you see a 17% reduction in hospital-acquired infections, that should translate to reduce costs overall in the system. So again, this stuff is like pretty dense too, so I don't want to get lost in the details and not make sure that I'm tying it back to the bigger picture here. So value-based purchasing, same concept. So hospitals have to report on benchmarks. They get measured based off of patient experience, safety, clinical care, efficiency, and Medicare is withholding 2% of their premiums no matter what, and they redistribute that based off of their performance on these benchmarks. So you have to, I think I've got it in here. I think I took it out. So it's not only that it's kind of where you are at baseline, and then how you rank in your peers is a little more complicated. But between the three different programs, you stand to lose a lot of money in your healthcare facilities if you're not getting on board with the program. Right, that's the gist of it. So I don't want to talk too much about these innovation centers. The short of it is CMS is giving a lot of money to states as incubators. They're trying to pull in public payers, private payers, providers, health systems. And they're letting them just figure out, how can you braid together funding and provide high quality health care, right? How can you make it more efficient? What can you do? And they're just giving them a lot of money and using them as incubators. These are called state innovation models. So a lot of them are using these innovation models to prop up accountable care organizations. A lot of them are using it to implement patient-centered medical homes that we'll talk about in a minute. A lot of them are using it to implement like bundled payment schemes where, I'll talk about that in a minute too, I don't want to jump the gun. So again, the idea is that they're giving them money, giving them tools and saying, figure it out. And once they go through that process and figure it out, then there's this translation phase where it's like, okay, what worked, what didn't, how can we take it to scale, and so on. That's the plan behind these. That's just a map of where they are. Tennessee actually has one of these innovation models. They're focused very heavily on bundled payments and episodic care, just so you know. So the key point here, I think I took that out. Did I take that out? No, I didn't. So the key points I already said, right? So again, they're trying to drive to reimbursement, use them as an incubator. The state innovation models collectively are still being evaluated, but there's a lot of data on some of the subcomponents. But these episodic care payments, historically, what they're trying to do with this is historically, when you go to the hospital, the provider who sees you can bill the insurance company, the hospital can bill the insurance company, the lab can bill the insurance company. If you get transferred to a step-down facility, they bill the insurance company. Everybody gets paid separate, right? Like that's how traditional payment works. What these are doing is saying, okay, depending on the admission, like there's certain admissions that are looking at that they get triggered by a DRG. You guys know what a DRG is? They know what a DRG is? Not yet? All right, let's just say that there are bundled payment groups where when you hit a certain code, like if you're admitted for like knee replacement, right? Like there's a DRG for that. So everybody that's involved with that DRG or that patient care, you all have this much money. You got to figure out how to make it work within that much money. That's called a bundled payment, right? It's kind of a capitated payment system. So you get an overall budget for a defined period, and it's up to you guys to coordinate it, make it efficient, and make sure that it works. If you spend more money than what we're going to give you, we're not giving you any more. If you can save money, then you can keep it. Like that's the gist of it, right? So far, there are 6 categories of these. 2 of them have actually shown to save a little bit of money, mostly around orthopedics, like knee replacement stuff. One is increasing, but most of them, right now, it's a wash. So the bundle payment stuff is kind of so-so. All right. Cognitive break. The accountable care organizations are a juggernaut right now. So I need you to be able to focus in. I'm not saying a bunch of crazy stuff, so I can see your eyes starting to get a little bit. And I can see the fatigue wearing in, so y'all just hang with me. I get it. I'm tired of listening to myself too. It's fine. So accountable care organizations. So you have a healthcare system that has a lot of providers, right? What's happened over the past several years is that a lot of health systems are starting to integrate, which means that you have a health system who buys up a hospital, who buys up physician practices, who buys up parts of the supply chain or the value chain, right? So like you have a health system, you buy the primary care, you buy the outpatient facility, you buy the hospital, you buy the long-term care facility or the step-down facility. So you got a lot of health systems that are requiring a lot of assets, right? There are reasons why they're doing this. Part of it is because of this reimbursement change. It's kind of a survival mechanism to reach economies of scale, leverage your purchasing power, leverage your negotiating power with insurance companies, things like that. But simultaneously, you're adding a lot of layers of care that aren't always coordinated even within the same system. So what accountable care organizations are doing is Medicare. It started with Medicare. It's expanded out, like even private insurance groups have iterations of this now. You have a group of providers who agree collectively to share accountability for the cost and quality services delivered to Medicare patients. Right? So you might have physicians and hospitals and step-down facilities saying, okay, we're all going to work together. We're going to come up with a contractual agreement, and we're all going to work together and make sure that we're taking care of this group of Medicare patients, and we're going to do it efficiently, and we're going to do it together, and we're going to figure out how to make it work. So why would they do that? Why would they do that? Yeah, because there's a financial incentive to do it, right? And the financial incentive is, there are 2 tracks. There's a one-sided track right now, which is called, just for analogy's sake, it's called, I call it carrots, right? So it's a purely financial incentive. If you can provide care and save money at lower cost, then guess what? You get to keep any extra money that you can generate. right? So we have a set amount of payment that we're gonna give for certain conditions. If you can come in under that target, then you get to keep the money. That's the one-sided track. The two-sided track is the carrot and stick, right? Where you're not only assuming the good, but you're taking on responsibility for the bad. So those, if you come in under cost and you save money, you keep it. What do you have to do if you come in over? You pay it back, right? Now, you can only stay on the one-sided track for a short period of time, like a year or two, and then you have to transition to the full risk-sharing model, okay? So they set spending targets every year, and there's a buffer in there, right? So you have to come in under those targets, which means that you're going to take the people that agreed to be in your accountable care organization. You all are darn sure going to figure out how to best deliver care because you don't want to pay any money back, right? Like you want to keep money. It's a way for you to make additional money. So if you see the buffer, yeah, you guys get it. So here's the trick here. What is the risk of that type of arrangement from the patient perspective?
Lack of quality care.
Quality, right? Like I have an incentive to not provide you care because it's going to cost money to provide you care, and if I do that, it kind of cuts into my profit margin, right? So there's an incentive to withhold care, and it can impact quality. So you only get these enhanced reimbursements, or you only get this enhanced payment if you meet quality benchmarks, right? So you can't sacrifice quality to get there. You have to do something different to make it happen. So just for the sake of terminology, there are pioneer ACOs, right? So when they first brought up this program, these are the early adopters. These are people who have been doing this before the ACA. They knew what they were doing. They recruited them into this program so they could kind of be exactly what they sound like, the pioneers of this project. Your kind of second tier are your Medicare shared savings plans. These are more traditional post-ACA folks who are still trying to figure it out. Now we kind of got to the point where we have these next generation ACOs, so the ones who have got it figured out a little bit and they're willing to take on even more risk reward, right? So that's kind of where these things are. If you look across the country, the darker the red, it's like the dark red are 15 plus ACOs operating. So you can see in Tennessee, there are 4 or 5 of them operating kind of in Middle Tennessee. Mountain States has an accountable care organization, right? Like these things are local; they're not far off in the distance. There's some states who don't really have a lot, and there's some states who are pretty engaged. If you look, there are over 600, 700 of these now, accountable care organizations that are out there. So there are folks who are getting together within healthcare systems across the country trying to figure this stuff out. So that's all fine and good. These things have been around long enough now where we do have some data on them. What's going on? What do you think's happening? Somebody who doesn't have their PowerPoint pulled up. How many of y'all think these things are actually saving money? How many of you think they're not saving money? We already established this last week. Not raising your hand is not an option. How many of you think they're saving money? How many of you think they are not saving money, they're actually losing money? How many of you all don't really care? Right. So, here's the short of it. There are 12 pioneer ACOs out there. There used to be about 20-some. Several of them figured out it really wasn't for them and they dropped out or switched to a different plan. So these advanced models, 8 out of the 12 will save money. Right? 6 of them save beyond the minimum where they earn payments. About half of them are actually getting money back for their agreements. A couple of them saved, they didn't know, like they saved with, it was basically a wash. They were still within the margin of error. 4 of them lost money, but only 1 of the 12 had to actually pay money back. Right? So that's what's happening with those. So they have a net savings of about $700,000. So they have saved taxpayers and Medicare, right? These 12 really advanced pioneer ACOs have saved $700,000. Right? Like that's not even dust on the budget sheet, right? But anyway, okay, that's the point, but it's not the point. So I'll let you think about that for a minute. That's kind of a mysterious language. So ideally, you want to save money, right? Like that gets returned to Medicare to help control costs or whatever. That's good. The real benefit of these are that you have groups of people sit down together and trying to figure out what the heck to do, and they're trying to take care of people better, right? Like, that's hard to measure, like, in financial dollars, right? Like, there are different ways that, you know, are people getting higher quality care? Are these systems more efficient because of accountable care? So in this case, I think it's, you know, the amount of money that's being saved is important, but I think that the bigger issue, or the more important issue, is how are these things changing the way that care is organized and delivered in practice? And if it's changing it for the positive, where people are working closer together, they're focused on quality improvement, and they're taking better care of folks, right? Like, that's going to have an impact on the system, and I think that's really what they're trying to get at. So there are 392 of these second-tier savings plans. I'll just cut to the chase. 189 of them lost money. By the time they paid everything out, those actually lost $216 million. So they're losing money, right? But again, I kind of view this as an investment, right? Like, the accountable care organizations, or CMS through the ACA, it's kind of like you have to give, like, it's like any other investment. Like, you have to put some money on the table to make change happen. And you may get your money back, you may not, but you're making something happen, right? Like, you're making a change fundamentally within the way that care is organized and delivered. And I really think that's the point of what's happening with these. So half full, they're saving money. The reality is also, I mean, these things are in their infancy, right? Like, you're trying to turn a barge in a bathtub when you're talking about turning around the healthcare system from volume to value. Like, it is not easy to do. They're still learning. They're still in their infancy. That's the data so far. Those numbers are still, I mean, the jury's still out, right? Like, we still are trying to figure out what's going to happen with them. You know, half empty, you know, it's not really that much money. Some of them are losing money. You know, one of the key issues here is that there's a lot of fixed costs involved with accountable care organizations. Like, you have to have a pretty sustained, like, you have to have a pretty robust infrastructure to even be able to venture into this, like, as far as electronic health records are concerned. Like, there's a lot of fixed costs, a lot of sunken costs that don't get accounted for here. So anyway, we're still waiting to see. Patient Centered Medical Homes, this was funded directly through the ACA, through CMS. The short of it is, they're pulling the money from CMS, pulling money from private insurers, and they're giving it to practices to take better care of their people, right? So we're going to give you a little bit of extra money, and what we expect from that extra money is that you're going to coordinate care, you're going to work in teams, you're going to engage your patients in a way that's meaningful, and you're going to manage the health of that population group in a way that produces better outcomes, right? So we're willing to give you a little extra money if you'll do these things, right? So I think you can see why these are getting rolled up into accountable care organizations. Like, this is a pretty good strategy if you're an accountable care organization for improving quality of care. They're giving you enhanced payment for value added, like additional things that you can provide that produce better care. Those are all the different medical home initiatives that are going on across the country. These things, again, predated the ACA. ACA is just trying to take them to scale. These are occurring in primary care facilities. These are occurring in FQHCs. You guys know what FQHCs are? Very Qualified Health Centers. You guys know what those are? I bet you'll learn about them if you don't. You guys been on those? Not yet? So there's a whole safety net network of clinics across the country that provide care to low-income families regardless of their ability to pay. And those are called Federally Qualified Health Centers. They get a grant from the federal government that helps them with their operating costs. Now, they can bill private insurance, they can bill Medicaid, they can still do all those things, but they have to take you regardless of your ability to pay. And they use a sliding fee scale for your fees, right? So you provide your income verification, they slide your fees based off of your income level, right? They're a critical component of the healthcare safety net for a lot of vulnerable populations, okay? Here's a trick question. just for your own edification, do you think the quality of care delivered in FQHCs is better or worse than what you would have in a regular private practice? So it's a safety net clinic, which means that it's taking care of people who can't pay. Do you think they get the same quality of care as private physicians?
It's understaffed usually and it has poor quality care.
How many of y'all think they get worse care than FQHC? Come on now, you ain't no fence sitters here. How many of you think they get better care? How many of y'all think it's the same? There's no difference in the quality of care. When you look at it in the aggregate now, I'm not saying that that's the case all over the country, but we're looking at aggregate numbers. If you look at aggregate data reported by FQHCs compared to other private physicians, there's no difference in the quality of care that they receive. And they also provide a lot more wraparound services, right? Like they provide a lot of social supports, community-based services that aren't really provided through others. But anyway, it's not a class of FQHCs, but I thought I would throw that in there. Anyway, you got about, a couple thousand providers, a couple million folks that are kind of in these models. So the results so far, right, this is what we're trying to get to. Most of them did well enough for CMS to break even, right? So CMS gave them a little extra money to do more value-added stuff. They did a pretty good job of doing that. Not really enough to save money, but better patient care as a result. There is some evidence that people who are in these patient-centered medical homes don't visit the ED as often, which is a significant cost savings to the system as a whole, and they're much less likely to be readmitted to the hospital. So there are some positive things going on around patient-centered medical homes. Even if they're not saving money, they're improving the quality of care, increasing the value of care that's provided, which may not save CMS money directly, but that has an overall impact on the healthcare delivery system. So here's the key point. They're linking payment to quality, which requires multidisciplinary approaches, which fundamentally shifts the way that care is delivered. It improves efficiency and produces better outcomes and hopefully is more cost efficient in the long run. All that, all those programs, all those initiatives, all those things that we just talked about were in the ACA. Okay, those are subtitles in the ACA, and the ACA allocated funding for these programs to fundamentally shift or force some differences in how care was delivered. So that's, again, it's all designed around producing better quality and controlling healthcare costs. So a couple honorable mentions. The ACA gives CMS more latitude to weed out waste, fraud, and abuse. So there's this idea that every dollar you invest in seeking out waste, fraud, and abuse returns you about $1.75. So if you allocate more funding towards finding those folks who are fraudulently billing Medicare, Medicaid, things like that, you can actually recoup more money over the long run. I got to do this. I can't help it. Where else do you see this? Where else have you heard of this kind of thing? We're going to find the people who are abusing the system and get our money back. Yes, 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 yes. Food stamps. More specifically, like SNAP. Any type of public benefit, right? Welfare, what would be considered welfare programs. So the narrative goes something like this. Taxpayer dollars shouldn't be used to provide services for people who are abusing drugs. Therefore, we should drug screen everybody who is applying for and receiving publicly funded benefits. And if we find that they are indeed abusing drugs, then they should not be entitled to receive those benefits. You guys heard that? How many of y'all have heard that? This is where I get in trouble on social media. How many of y'all think, wish I had like a little poller. How many of y'all think that those programs, drug testing, public welfare beneficiaries, how many of y'all think that actually saves money over the long term? How many of y'all think that it saves money? You're finding the abusers. How many of y'all think it doesn't? All right, you guys are getting smart. It doesn't. You spend more money. And these type of studies have been done in like 8 or 9 states that have implemented this policy, right? Like this is consistent across the board. You spend more money drug testing welfare beneficiaries than you save by identifying them and pulling their benefits. Okay, let me ask you, is that an efficient use of public resources? But does it make you feel good that you got them?
Yeah.
Yeah, right. Again, these are the kind of dialogue that we have to have. Like this makes people feel good. Like it makes people happy. It is a horrible public investment. You're spending more money to do something to find a few abusers that you can get in return for what you spent to find them. Okay, that's not the case necessarily with waste, fraud, and abuse in Medicare. If you invest a little bit of money in seeking it out, your returns are higher. That makes sense?
Yes.
It costs you more money to drug test than you can recoup in benefits when you've busted them. Anyway. Prevention and wellness. Not much to say about that other than it always is the stepchild of any discussion around health. There are some provisions in the ACA that tried to increase funding for preventive health stuff, traditional public health activities. It didn't pan out quite like it was originally slated. There's some things going on, new councils, prevention and public health fund, more activities. Even as a public health person, I don't really think that these have been. I'll put it this way: whenever they're trying to cut back funding, what's the first thing that gets pulled back? This kind of stuff, yeah. So, controlling costs. ACA cost less than originally anticipated, right? Some of that's because Medicaid didn't expand and so on. It's costing about $2.5 trillion less than what it was originally projected to cost. This is important. Healthcare costs are growing. They always have, they always will. But they are growing at a less significant trajectory under the ACA than they were growing before the ACA. Growth is at a 50-year low. Healthcare cost growth, or healthcare expenditure growth, was at 4% in 2015. This is what it looks like. This is when the ACA went into effect. This is healthcare growth since the ACA went into effect. Look back here in the 90s. This is when the recession started, so you would expect to see that happen because people are vulnerable income-wise, therefore they don't use any services at all. I need y'all to think about this. What have we said? You increase access to health insurance for 20 million people. Okay. Does that cost money?
Yep.
Yeah, it costs money. Despite the fact that you extended coverage to almost 20 million people, healthcare expenditure growth since the ACA is at 4%, which is lower than it was leading up to the ACA. I need y'all to think about that for a minute. What's the criticism of the ACA in the public domain? It's killing the economy. It's healthcare costs are rising, skyrocketing. Skyrocketing is the word you always hear. This is the kind of stuff that makes me mad. Are healthcare costs increasing?
Yes.
Yes, they do every year. Are they increasing more now or less now than they were before the ACA? Less. So you extended coverage to 20 million people and healthcare expenditures are less than they were before. It's ridiculous, right? Like that's a false narrative. That's a false narrative that's being put out. It's just not true. It's disingenuous. Now, hands above the table, part of that's due to the recession, right? That's just a reality. It's not entirely due to the ACA. It's not like the ACA is saving a lot of money, therefore things are happening the way they are. The recession had a lot to do with that. But we're talking about 2017, 2018. We're kind of over here now, right? Like the recession is kind of over and done. and the wheels are not falling off the wagon. You extend the coverage to 20 million people, healthcare costs are growing at less of a pace than they were before the ACA. Okay, the wheels are not falling off the wagon. Is healthcare expensive? Yes. Right? But you were able to extend coverage to 20 million people without blowing up anything other than people's false perspectives of what was actually happening, right? So that's where the money they pay for it comes from. We're not going to talk about that. So, okay. We're almost there. You guys are champs. You're hanging in there, even with the little dark room and whatever. So let's talk about some of the key issues that are problems or potential problems with the way it is now. One of the big issues right now is the stability of the marketplace, right? Those premium stabilizers that we talked about earlier are gone. Healthcare costs, premiums are going up significantly for folks who bought private insurance plans through the market. Okay? That's what it looks like. So all those orange areas are places where you're seeing, well, the darker orange are double-digit increases in health insurance premiums, right? So this is a county-by-county map, right? So these plans are offered by county, okay? I'm going to point out, when I tell you that, I have friends in Tennessee that have seen their premiums go up. See that little dark orange right there? Yeah, it's going up in Tennessee, particularly East Tennessee, right? There are reasons for that. One reason is Tennessee didn't expand Medicaid. So, premiums going up in West Virginia, North Carolina, parts of South Carolina, Florida, Mississippi, Texas, Louisiana, thank you. I grew up in Kentucky. Right. What's the flip side of that? This blue are double-digit decreases in premiums. There are parts of the country where premiums are going down. What is that? Mexico? Some of the Midwest, right? Like a lot of counties up in New England, Georgia. So when we talk about stabilizing the market, what we're seeing is there are parts of the country with the way that the ACA is going and the way that the private insurance market is going, there are parts of the country that are getting hammered with premium increases. And those tend to be states that have a lot of poor folks, a lot of vulnerable populations. There are states that didn't expand Medicaid. Why would Medicaid expansion help keep premiums down in states? So let me back up and say this. In states that expanded Medicaid, let me skip to this slide. This is just like another way to look at this. Is looking at some major markets at what's happening with premiums. Why? Okay, let me back up and state this. In states that expanded Medicaid, the average increase in premiums right now is 7%, right, which is bad, but it's not horrible. The average premium increase in states that didn't expand Medicaid is 20% right now. Okay, why? Why? You got to put your thinking hats on. This is a pretty complicated question. Why would Medicaid expansion help keep premiums down for people in the private insurance market?
Because the number of sick people is Medicaid.
Anybody want to venture a guess, or you just want me to tell you?
Who's sicker?
Cover the poor, who are mostly the same.
So the number of low-income people who are usually the ones who get sicker are the ones who get, the opportunity to go into Medicaid, it was expanded. But without Medicaid expansion, then you have more of those who have to use private insurance.
Yep, partly. That's 90% correct. You're correct, but you're missing one other additional piece. So I don't know if you want to hear what he says. So what's happening is, So like, you have a lot of folks who are in poor health. They typically are lower income folks, income vulnerable, typically sicker, which is why they don't have insurance in the first place, okay? So the states that expanded Medicaid, a lot of that group of folks were able to get covered under Medicaid, so that pulled them out of the pool that was buying insurance in the private market, if they could afford it, right? So there's some questions around that. So they kind of got pulled into public sources, which left what in the private markets in those states? Higher income folks that might be a little bit less of a risk to the insurance company.
Yeah.
Right? That's pretty much what's going on. Right? So in states that expanded Medicaid, you kind of pulled a lot of those high risk folks out of your private insurance market, and they're covered under a different source. So your risk pooling in the private market is more favorable. Right? So therefore, premiums in those states tend to be lower, like they're not going up at the same rate. Right? The other issue is that in states that didn't expand Medicaid, there are two things happening there. One is there's still a chance they could be buying plans through the market, right? Even if they may or may not have qualified for the subsidy or they're in the gap, there's still a chance that a lot of lower income folks are still buying plans through the marketplace that are probably sick, right? But the more likely scenario is in states that didn't expand Medicaid, what's happening? What are those folks who didn't have insurance before doing now? They don't have insurance. They still don't have insurance. What are they doing? Emergency room. Like it's the same scenario before the ACA, right? Like they're still going to go to the doctor when they're sick, right? I'm going to get to your question. I got to finish this point before it slips my mind. When people who don't have insurance go to the doctor, what happens? Do they pay for it? They may try. I don't want to assume that they don't. But that usually ends up being what? Uncompensated care. Okay? What do you think happens when hospitals and providers provide care that is not compensated? What do you think happens? Yeah, they shift the cost for what they lost. Sometimes they used to get it from the federal government with disproportionate share payments. Right? Like the government used to pay hospitals a certain amount of money depending on what proportion of the uninsured they took care of. That went away with the ACA because they were expecting everybody to have insurance. Okay, unintended consequence. So you've got providers, uncompensated care costs are not going down in those states because they're still taking care of those folks. Do you think the hospitals are going to eat uncompensated care? No. What are they going to do? They can't shift it to Medicare and Medicaid because those reimbursements are fixed under costs. Who's the only person left to shift it to? Private insurance. Right, so why are private insurance premiums going up in states that don't expand Medicaid? Unfavorable risk pooling, and you've got a lot of uncompensated care that's going to have to be accounted for somewhere. You see what's happening here? This is complicated stuff, and this is my argument for. That clock right? This is my argument for publicly funded programs. Okay, before the ACA. When uninsured folks use healthcare facilities and healthcare services, it goes to uncompensated care. There's pretty good evidence that shows that as Medicare and Medicaid reimbursement gets lowered, you see a shift in the percent of costs reimbursed by private health insurance companies. So all those things are related. So when you have a lot of uninsured folks using your facilities, you have a lot of uncompensated care, right? When Medicare and Medicaid tinker with their reimbursements and pay you less, you shift it onto private insurance. Uncompensated care that you can't get reimbursement from the federal government gets shifted onto private insurance. Okay, that's why premiums, like I showed you all a graph last week that showed healthcare premiums going like this, going back like 40 years. That's why they go up. That's why private insurance premiums go up so fast, regardless of the ACA. This was happening long before the ACA, and it's because of that very reason. Uninsured folks use services, Medicare, Medicaid tinker with their reimbursements, all of that gets shifted to private insurance. Whether it's employer-based private insurance or whether it's private-based insurance through the market, but either way, employer-based insurance is, to some degrees, there's a buffer there because the group is so big, like the pool is so big, but the people who really get hammered with this are the ones who are buying private insurance policies in the private market, right? Here's my point. You're paying for the uninsured whether you know it or not.
Yeah.
Because that cost is getting shifted to you indirectly, you just can't see it, or you don't see it, or you don't put the two things together, right? It's getting shifted to you one way or another. Call it taxes, call it premiums, call it whatever, but you're paying for it one way or another. Okay, so I'm gonna say about that. So in 2014, you had about 7 or 8 insurance companies per state offering plans. In 2018, that's down to about 5. Pretty straightforward. Insurance companies are pulling out of the markets. We've already talked about that. So there are some states that only have 1 or 2 insurance companies offering plans in the market. Now, they may offer 200 variations of that, but it's one company. So, repeal and replace. You know, if these plans go through, you can expect the number of uninsured to go back up. And this is an argument that I have with people all the time. People are complaining because their premiums are going up under the ACA, and I get it. Like, I totally get it. But if you have the uninsured flooding back into the healthcare market with uncompensated care, do you think your premiums are going to go down if you repeal the ACA? No, they're probably going to get worse, right? So, like, the logic just doesn't make sense to me. Uncompensated care costs to providers, right? Like, that's a big deal. Let me point this out real quick. I should have flipped these around. That medical loss ratio I told you about. So this looks at the first quarter for every year since the ACA. But I told you those premium stabilizers ran out. That had a big impact in 2015, 2016 on insurance companies. They were losing money. Like when they stopped getting the reimbursements from the federal government, they were, 88% of every dollar they pulled in went back out in paying claims. Right? So when you say the insurance market was destabilizing, that's a pretty good indication that that's true. Like they were not making as much money as they had in the past. But look at this. First quarter 2017. Settled out, right? Premiums went up a little bit more than what folks are comfortable with in a lot of places. But overall, in the first quarter of 2017, that medical loss ratio is 75%. They're not losing money anymore. Right? In fact, if you look at the average premium versus the average claim per person, you can see very clearly they're not losing money anymore. Right? So this is not the only metric, but this is suggestive that that jolt to the private market following the loss of those subsidies from the federal government, coupled with kind of a, stable, like with the fact things are settling out, right? Now that things have settled out a little bit, evidence suggests that that market is fairly stable, right? Like now it may have settled out at a higher premium than folks want, but it's accurate. Like it is what it is. That's a market now. Like that's the risk that you're posing to the insurance company for the people in your pool. That's what they're paying out, but it's stabilizing a little bit, right? So it's not totally unstable now, right? So that's a good thing, right? So when I hear things like, well, just let the ACA implode under its own weight, I'm like, you know what? That's a fantastic idea. That is a fantastic idea. Just let it go and see what happens. Because every metric that we've looked at so far suggests that it's stabilizing. If you want it to implode under your own weight, fine, because it's not. In fact, it looks like it's stabilizing. So, go figure. uncompensated care costs dropped from 3.9% to 2.3%, right? So health insurance or health providers who were taking care of a lot of folks who didn't have insurance before, what's happening to them now? They're getting reimbursed for stuff they used to not get reimbursed for, right? So that's about $6 billion reduced in uncompensated care costs to hospitals and providers. Okay, if you want to know why, healthcare providers, insurance companies, advocacy groups, and 6 red state governors all agree that this new plan is a train wreck waiting to happen, okay, those people don't agree with each other, right? Insurance companies fight with hospitals. Okay, providers fight with everybody. Okay, but they all agree that this is going to be a problem. Do you know why? Insurance companies, because it's going to destabilize the market, and they know it. Okay, providers and hospitals, their uncompensated care costs are going right back up, right? So you better believe that they don't want this to go through, because they're the ones that are going to suffer as a result, and it's going to hit your low-income providers and facilities that are taking care of the most vulnerable populations, right? Like, that's the cycle that we're dealing with. So here's the thing, is Medicaid expansion is a key component of this, right? That 70% of that reduction occurred in states that expanded Medicaid. So in states that didn't expand Medicaid, you're not seeing that type of reduction in uncompensated care, which goes back to the point that we were making earlier. So, am I out of time yet? Okay. Here's my takeaway. You've expanded coverage to 17 million people who didn't have insurance before. Healthcare growth, regardless of the reason, is fairly modest. Okay, the wheels haven't fallen off the wagon. There are folks who have been hurt by the ACA. There are folks who lost insurance under the ACA. There are folks who had to buy insurance plans that cost them more, and their premiums are going up exponentially under the ACA. But when you look at it at the macro level, net gains, net losses, the overall impact on people and the healthcare economy, the wheels have not fallen off the wagon. In fact, I would argue you've been able to expand coverage to a lot of folks, and you really haven't had to. You really haven't had to pay too much of a consequence relative to what would have been occurring, regardless of whether you done it or not. So to me, that's a positive. Okay, and I'll end with this. There are studies that have done this. Like, I'm not making this stuff up. When you ask people if they support Obamacare, what do you think the answer is? It's not no, it's hell no. Right. When you don't call it Obamacare and you say, okay, well, do you think that insurance companies should be allowed to deny coverage for pre-existing conditions? Well, no, that's unethical. Do you think that people should be able to stay on their parents' health insurance through 26? Well, sure. Do you think that health insurance companies should stop paying for coverage when you reach a certain threshold? No, that's horrible. When you take the individual components of the ACA and just look at the merits of them based off of what's in it, people overwhelmingly support it. Okay, so it's all about labels, it's all about perception, it's all about what you call it, how you brand it, whatever. And what I really hope that you all take from these past 2 weeks is the ability to think and see through that. Okay? You don't have to agree with me. You can have a very different take on it. That's fine. I just want you to be able to understand the arguments, have enough cognitive compartmentalization where you can reasonably think through what's being presented and find the information that will give you some type of indication as to how accurate it is and think through it on your own. That's what I want you to take away from these past 2 weeks, is the ability to do that and not get distracted by all the stuff that you hear as a graduate student in public health with an interest in health policy, because even if you are a different major, I'm pretty sure I've converted some of you all to what we do. This is important stuff. And regardless of how you feel about it, you need to be able as a graduate student to look at the data, look at what the evidence suggests, and formulate your own positions and opinions based off of critical thinking and data, not sound bites and propaganda. And that's all I'm going to say. You guys have been great. I've enjoyed the past 2 weeks. I'm going to turn it back over to Dr. Beatty, because I'm sure you got some kind of homework to do.
Alright, you guys know what you have to do. I hope you're inspired to do your health reform brief now after this week. And if you have any questions, let me know. Watch that short little video, go over it, and I'll see you next week. We're gonna totally shift gears next week and talk about partnerships and leadership. And a lot of what we're talking about next week will inform part one of your project. So we're gonna